podcast or YouTube channel, Blue can make you sound and look great. The World Health Organization estimates that each year approximately 1 million people take their own life. That's one death every 40 seconds. Experts predicted numbers would peak in 2020, but no one could have imagined the devastation brought on by COVID-19. During the coronavirus pandemic, you may experience anxiety, sadness, and loneliness. Existing mental health conditions, including severe anxiety and major depression, may worsen. If you're feeling hopeless, contemplating self-harm, or you're concerned about someone else, I'm here to tell you there is hope. A Mission for Michael is dedicated to helping clients achieve complete inner and outer transformation. Mission for Michael is the premier resource for intensive mental health treatment in Southern California. With an astonishing 2-to-1 client-to-staff ratio, each client in their facility receives individual care 24 hours a day, overseen by a team of all doctorate or master's level clinicians. With a focus on evidence-based treatment, along with personalized and compassionate care, they offer mental health treatment that can change lives. If you're suffering from mental illness or you're concerned about a loved one, go to amfmtreatment.com. Again, that's a mission for Michael, amfmtreatment.com, or call 866-581-4401. Again, that is 866-581-4401. I am so grateful for our friends at Blue Microphones. Not only have they completely changed what our show sounds like, they've given me headphones so I can monitor things better. This is the mic for millions of creative people, and now I know why. I'm so grateful for them completely changing the quality of our audio. You'll find Blue mics like Yeti and the Mouse, which we're using here, both in pro studios and home studios, literally all over the world. Their popular Yeti caster is a Blue Yeti microphone, plus a boom arm system that's behind many of your favorite podcasts. I run into them all the time, and now I know why. If you've ever thought about creating your own podcast or YouTube channel, Blue can make you sound and look great. Just visit bluemic.com and click Get Started, and you can start telling your story.
Hey, everyone. It's a dose of Dr. Drew.
Here we are, everyone. Dr. Yogendra will be here in just a minute. We're going to talk about the latest stuff on COVID and some of the newer treatments for the cytokine activation syndrome, the cytokine storm, as well as some of the immune mechanisms around immunogenicity, and some new clotting studies came out today. All kinds of interesting stuff to get in the weeds about for him and I. When's he coming in here, Susan?
I don't know.
Soon. I don't know. All right, fair enough.
When he's ready. When he's damn well ready. He's Dr. Yo.
Doug Brun, the death rate is not 1% all ages. That is true. The death rate is 1.15% overall. Obviously, it's much higher in the 80-plus year old and much lower in the under 20-year-old. So there you go. So there's that. Yes, thank you for the Blue mic link.
Go to drdrew.com/blue.
Yeah. Any thought? Everyone recovered from the election? Everybody's anxiety okay? We got to be good with whatever. It's the system, and the system is doing its thing. What's that, Susan? You think?
Test that, Dr. Drew. I haven't looked at it in a while, but I think it was Dr. Drew.
Here's a good question. The thoughts on Oregon decriminalizing drugs. That's a really great question. I am always in favor of decriminalizing addiction, okay? And that they're talking about using some of the funds to fund treatment and whatnot, which is also great. The problem is the operation of those laws end up being enabling. They end up preventing law enforcement and medical practitioners from getting in and treating these people. You have to have a carrot and a stick. You have to have both to get people into treatment, or they will not go. So if you just legalize drugs and don't give any kind of ability of practitioners to bring people in when they're doing dangerous things that could kill them, you're going to kill people. So it's a mixed thing. We'll see how Oregon puts it together. Generally, the way that most states do it, California has done it, is just absurd. It's killing people at a rate of 4 a day just in Orange County alone. So here you're allowed to do drugs, traffic drugs, and steal to support your habit. And we will give you needles, not needle exchange, just hand you needles. You have to ask drug addicts to do something. You don't just go, hey, just go do drugs, do whatever you want. That's a fatal prescription. That's how to get people to die. So, we'll see. We will see what Oregon comes up with in that. I generally, Indiana's going to legalize marijuana, I guess. So we've been here in California with legalized cannabis for quite some time, and we're okay. I mean, there's lots of problems. People are getting into issues with it, and lots of people are getting help by it. Both. It goes both ways. It has problems and it has benefits, like everything. Cardiomegaly, hydrolyte immunity. I don't know quite what you're asking for, Hart. Cardiomegaly, meaning you have a cardiomyopathy. You should not be taking sodium loads, so hydrolyte would not be a good thing for you. How is alcohol legal and weed isn't? Right. So, yes, our laws around drugs and substances are really bizarre.
What's up with a dog?
I don't know.
Oh, look.
Yeah. And again, we're going to have Dr. Yogendra in here in just a minute to talk about stuff. We'll see what's new in the treatment world. Let's see. GSR loves California because of legal weed. Okay. Yeah, I mean, it's, I've always said the whole medicalization of marijuana was a sham just to move things towards legalization. So let's just legalize it and get over it and see what happens. I think one of the horrible things is the fact that there are thousands of people locked in prison for ridiculous, most of their life because of a 3-strike violation around cannabis. That's insane. That is a terrible thing. And again, that's different than decriminalizing heroin, say. I mean, because that is such a dangerous drug, and you need to be able to motivate people into treatment. There's got to be forces at work that help you get people, as opposed to prevent people from getting care. Okay. Yeah.
It was a pharmacy.
I've got your Ivermectin coming, Susan. We'll talk to Dr. Yo about that. Ivermectin. We got to discuss this. I got to remember that. And also, there's a really interesting study about dipyridamole, persantine, which is an old medication I have not used in 20 years, but suddenly it's back for the treatment of COVID. So interesting. Can I keep cholesterol down while on the keto diet? Matthew, absolutely. Check out Dave Feldman's work. He talks about that. I myself, there's some data that shows that the triglyceride and the HDL is probably more important than the LDL, particularly with certain genetic subgroupings. I have a high LDL that would never go down, and I have a lot of large vessel vascular disease in my family, so I got on a statin 25 years ago, and my LDL has been, with just a quarter of a tablet of Vytorin, my LDL has been pegged down at nothing. Now, the first time I could ever get my HDL up and my triglycerides down, my HDL was normally 30, my triglycerides were normally 200, was on the keto diet. And I went from HDL of 30 to 60 and a triglyceride from 200, 250 to 75. Never in my life have they been like that. So clearly that diet has been beneficial for my genetics.
Wah, wah.
And by the way, I went and met with these guys today. You guys have seen this thing? I'm not involved with them financially at all, and they don't. But I just love this so much.
All right. Well, we have other people you need to talk about, like
what's
the
that?
Microphone and Hydrolyte.
Yes,
and
yes,
AM,
yes.
FM.
See, Susan's the slave driver here. Even though I'm enthusiastic about a product, I got to remember.
They got to give me money before I'm gonna let you promote them here. Okay.
All right. Okay.
Sorry. We have better ones. But if you get it, if you work with them, I won't have a problem.
Okay, it's just a good product.
I'm
using it to my benefit.
It is, and I like it when you use it on me.
Fish oil helped your triglycerides.
Okay, we have a guest here.
Is Yogendra here?
I hope he said it right. Okay, he has to put down his Game Boy.
No way. There's no way he's spending time doing Game Boy. That's not possible. There you are. Hey, man. How are you?
Hey. No, it wasn't my Game Boy. I just got the new iPhone. So.
Nice, congratulations! Is that a 12?
Yeah, well, that's because I cracked my other phone. So I've been trying to make conference calls and I can't. I'm like, excuse me, can you connect me because my screen is cracked? So
this looks great.
It's kind of embarrassing when you're having important calls with people. And
I understand. I understand.
Yeah, we get it.
Let me ask you this: can you talk about that landing page you sent me today? Can you discuss some of that?
Yeah, that's the long hauler project. We're probably a couple of days away from really launching everything. We're putting a couple of teasers up on Twitter.
Can I share that page with the group I work with over at Additics, who wants to be able to give you some of this diagnostic stuff?
Can we hold off on that just
All
for
right.
a couple of
All right, tell me when. Let me know when.
No, I definitely will. It's coming soon, and literally the next couple of days.
Okay.
So, just for your viewers and everyone watching, one of the big topics now the media is talking about is long haulers or the chronic COVID patients. It's very interesting. Dr. Drew, some of our earlier discussions, you touched upon the mental health aspect
Yep.
of COVID, of acute COVID-19, and also I think you brought up about the post. People that are recovering, the mental health,
Well, and what I was saying was also when I used to run medical services in a psychiatric hospital, this was late 80s, early 90s, tons of cases of post Epstein-Barr, chronic fatigue syndrome, all these crazy things. And there clearly was something going on with some people who had a severe viral syndrome and then were stuck in this sort of what used to be called neurasthenia. They just were kind of losing weight and weren't sleeping and were depressed and, lots of protein symptoms, fibromyalgia. And I think that's what we're seeing here too.
Yeah, I concur. I think, sometimes we get so focused on the actual infection, especially when you do critical care medicine, you're in the hospital, that we don't realize that there's a long-term, and usually it's patients, it's physicians that are in rehab medicine, physicians like yourself doing a lot of outpatient treatment. And less of the guys in the hospital like myself and sort of doing critical care and in the operating room, because we treat the problem, ship you out.
Yep.
And what's really coming to light is there's a large cohort of patients. I think we knew this back in May or June. Again, we're still trying to figure out this virus, what works, what doesn't, and all of that. But now we're having these people that, if you think about it, you look at the numbers of patients that are recovered, you're talking about the mortality rate is pretty low. And we're talking about 90 plus percent of people are recovering. And what that percentage is, we don't know. But anywhere from 30 to 60% of some of the data coming out are long haulers. And long haulers are from the onset of symptoms 2 weeks after they're having all sorts of symptoms. And we can talk about the immunology, we can talk the symptomatology. I'm not even joking, hundreds of patients. This is what I do in my downtime. I'm on WhatsApp all over the world. People are calling me. And this is the thing, I get off the phone with them and I'm so depressed. I'm so sad. Because you can hear the helplessness, the despair, there's actually one of the most motivated groups of people. They're looking for something. There was one lady that called me up and told me she spent close to $100,000.
Oh my gosh.
Going for different testing, MRIs, CAT scan, institutes,
EMGs,
like everything, every single workup you can possibly think of. And some of them are flying to other parts of the country, different parts of the world. And the most demoralizing thing is when some healthcare providers are telling them, there's nothing wrong here, go home.
So what is the plan? What are you guys going to do for them?
Yeah, so one of the testing we started doing was looking at the immunology. Dr. Patterson is, you can look at the top layer of labs, your CBCs, your chemistries, maybe even look at, the CBC with differential, looking at your white cell count, your neutrophil count, but we're looking at things a little bit layer. We're sort of, that top layer, we're going a little bit deeper. And we started looking at the immunology profile and the cytokine profile of these patients. And our hypothesis really came from looking at data from SARS and MERS and the long haulers from them and some of the literature, which was suggested that pro-inflammatory cytokines, which are the messenger proteins we've talked about, contributing to that cytokine storm, might also be the residual cytokines might be causing some of these symptoms. But SARS and MERS were not, they were just a short period of time, and they were just localized geographically. Those epidemics are really quickly contained. So there was a lot of data and not a lot of immunological studies. And when you look at the symptomatology of these patients, there are a lot of like these rheumatology and some of these pain management, chronic fatigue, fibromyalgia, whatnot. So looking at symptomatology, looking at the immunology, we started testing patients, and we started seeing spikes. And these are healthy, no medical history, and no medications. These are healthy 25, 30-year-old people all over the world. And we started seeing elevated cytokines. It's a heterogeneous pattern of these cytokines.
Okay, so there's nothing characteristic about it, nothing diagnostic about it.
Well, this is what we thought until about a week ago when Dr. Patterson, now him and his bioinformatics team at IncelDX, started looking at the data and diving into it. And what they found is they've determined from their analysis, and this is the paper we're releasing in about 2 weeks, that there are 5 markers that we call the long hauler signature. And it has a couple of really important implications, because really this is the first time we believe that we can now identify or actually have a test that shows that long haulers exist. For example, someone has chest pain, we do an EKG, we see ST elevations.
Right.
We have a test for this. We have a
Right.
test for chest pains or pneumonia, whatnot. Now we think that if you suspect you're a long hauler, or at least also to our friends and colleagues in the medical community, look, we have a test that we can do an immunological profile. And if these patients fit this signature, then they are a long hauler or a COVID-19 long hauler. And what's interesting, the 2 of the major parameters or the 2 of the major cytokines are, the first one is interferon gamma.
Okay. That's one of the markers.
It's one of the markers, yeah. And the third one would be RANTES, which is what Dr. Patterson said is the major player.
RANTES are up?
I'm sorry?
RANTES?
Yes, RANTES.
Up?
RANTES. Yes. It's the third.
So these are all up. Interferon gamma's up. RANTES up. Yes.
Yeah. Interleukin 2 is the second one. RANTES is the third. Fourth is CD14, CD16, and those are T cell markers that we've identified. So, and the test, according to Dr. Patterson, we're still looking at more of the data, and like I said, put out this paper, but he's saying his algorithm is 100% sensitive and 100% specific.
To having long haul. And if somebody doesn't fit that profile, are we calling them something else?
We're still trying to determine that. That's a question I'm not sure about right now.
Okay.
But all of the 30 patients we've analyzed so far all fit that profile, which is pretty remarkable. And it's great that we can test, but it doesn't mean anything. I always talk about that disconnect sometimes between the research world and clinical medicine. If we can have all these cool tests in immunology, but if we can't make clinical relevance and make people, so the next step we started doing is, after testing these patients, these COVID-19 long haulers, is we've now started to treat them.
With what? What are you treating with?
Well, this is the big puzzle. This is where most of our resources and time are going to go into solving this conundrum. Yeah. This is sort of a new venture. We are sort of approaching this like a new disease. And one of the first line treatments is steroids. And a lot of them are responding to steroids. They're responding not only symptomatology, but I just got some reports from Dr. Patterson maybe about 2 hours ago, where some of these patients actually, you're seeing the immunology, the cytokine levels go down. The RANTES, the interferon gammas go down after about a week of steroids. So, but then there's also another cohort of patients that are not responding to steroids, and usually those are the ones that are screaming and so upset because they're thinking, okay, it's a hyper-inflammatory condition. If I'm not responding to steroids, this is the end of the world. Right. So, the second drug that's showing a lot of promise, I know you and I sort of had some offline conversations about this, is the drug Maraviroc. That's spelled Mararviroc. And it was a 2007 FDA-approved medication for HIV. Its mechanism of action actually occupies that CCR5 receptor, which is part of that CCR5 RANTES axis we've talked extensively about. And this sort of idea came about because with the elevation of RANTES, we thought that by giving this medication, again, it's FDA approved for HIV, we could off-label it. Right. And any side effects from it? There is, so the major one, there's a black box warning. It's got a liver toxicity. But if you look at the studies that Pfizer did, It was on the one patient they were really concerned about was HIV positive, hepatitis C, and she had she had been taking this medication. So the dose is 300 milligrams BID. That's twice a day. You take it for the rest of your life. And I think she had some liver enzymes, liver transaminases elevated. But when we're talking about COVID-19, whether it's active or we're talking about the long haulers, we're not looking at more than a week or 2 weeks of treatment.
Right.
And
right.
I think with, like in anything, we talk like Tylenol, for example.
How about leronlimab?
Leronlimab it doesn't have, the side effects, it's got a great safety profile. The liver toxicity is not an issue, but the problem is it's not FDA approved. And even if the FDA did give an approval, it would be an emergency use authorization. And the scope of where it could be administered would be very narrow, in my opinion. They would come and say, okay, you can treat your active, severe, and critical COVID or your hospitalized patients. But it doesn't make any sense I don't see a role for it right now in treating these long haulers who are outpatient or out, they're in the clinic. The FDA is not going to give me a EUA, an authorization to use this drug.
Right.
That's why we started looking into Maravrat. 2 patients have been treated so far, and within 4 days, I want to be very careful by saying their symptoms have gone away. I don't want to make it seem like use the word cure. I know a lot of people ask me, well, what's the cure for long haulers? And I like to use that word cure. But we've resolved their symptoms. We're measuring their immunology, and we're just going to be tracking them. And the overall project, so it's a chronic COVID treatment center. And what it entails is there is a mental health component, there's the diagnostic and immunology component, and there's the physician consulting that's sort of overseeing all of the testing and all of the onboarding and the behavioral sort of the assessments that we're going to be doing. So patients would come in, they would put in their information, get the immunology testing. Mental health therapists and behavioral therapists will be working with them, not only assessing their immunological responses, but also their sort of how they're responding to the overall treatment, giving that mental health support. I think Dr. Patterson and I, one of the most startling and shocking things, like I said earlier, was just that despair, the feeling of hopelessness, feeling like the medical community, the society just turned their backs on them.
Right.
People, Dr. Drew, there are people that have told me they're on disability. They quit their jobs. They're debilitated. And now I'm running out of my wellness center in Rhode Island. I got a long hauler, like blood draws. I'm doing all the blood work because, right now we're still under the sort of falling under research protocols. And in a few days, we should have the kits validated. So
cool. Excellent. So I want to talk about a couple other topics too. I sent you an article just out about the use of dipyridamole for the excessive clotting associated with COVID-19. I thought, boy, that is an old medication I've not seen used in a long time, but here it is coming back. I think I would take that if I think I would start using that immediately for severe COVID.
It's, one of the nice things about, again, I'm not a big fan of using injections and IV drugs, and again, if I can take oral medications, it's always I believe dipyridamole is a PO medication. Mm-hmm. So I do feel that those type of drugs are much more, I guess, user friendly,
benign,
friendly than sticking myself with sub-Q injections of heparin or Lovenox, or even taking something like Coumadin, which has a lot of side effects.
Yeah. And dangerous side effects too, especially when somebody's sick, right?
Yeah, and the thing with the APL, the antiphospholipid, the antibodies, there seems to be a lot of discussion about that. I think that article, I sort of glanced over that you sent me, because we are starting to see, I think there was a study or some reports that came out, a couple of doctors suggested that a lot of that patients had elevated the antiphospholipid. And
I got to tell you, my patients with pre-existing antiphospholipid did extremely poorly with COVID, like uncannily, like boy, it's so almost like a different syndrome than other patients.
What did they like? What did you see? Was it just the severity of their symptoms?
Severity and rapidly progressive, with like a freight train. Like it just nothing seemed to be able to responding to nothing. And it was early in the fog of war of this disease. I was seeing some of that, and there was not a lot to be done back then, to be fair. But steroids were around and not doing anything.
Yeah, it's interesting. When I start looking at, we start to, there's a lot more research going in, and my interest is always like, let me see if I can connect the dots. And I'm not afraid of trying to connect the dots and being wrong about it. I think I always just ask the question we should all be asking is why? And why is this? And taking what Dr. Patterson is saying in the lab, and this is sort of a hypothesis of mine, I've been sort of brainstorming it with Dr. Patterson, is could the elevated interferon gamma, because we know that interferon gamma stimulates the macrophages, it's produced by the T helper 1 cells.
Mm-hmm.
Could it stimulate macrophages, and could it also be stimulated? We know it stimulates B cells,
mm-hmm.
those IgG. So we know that the antiphospholipid antibodies are made by the plasma cells, and could the interferon gamma, maybe there's some dysfunctional pathway that's taking place here, where these elevated interferon gamma is causing, because there are these, in normal immunology, there are these checks, these B cell checks that prevent these plasma cells from making what we would call those autoantibodies.
Right.
And could there be some aberrant pathway here that is causing the interferon gamma we're seeing in long haulers to cause an elevation in the antiphospholipids? Again, that
doesn't fit. I don't know. I mean, it's a good question, but it doesn't fit my gestalt, my sort of instinct on this biology.
Again, Dr. Drew, these are all, my brain's always looking at connections.
Yeah, I get it.
I'm not afraid to being wrong. So I'm not coming here to be like, well, this is my book I'm writing about. But
I think when I think about my patients with antiphospholipid, definitely macrophage involved, definitely some sort of endothelial cross-reactivity, definitely cytokine activation through RANTES, I would say. But that's about as far as I can get with my instinct on what the average antiphospholipid patient is like.
Exactly. I mean, the thing is, it's more about can we connect it to this? And so we have this outlier of these antiphospholipids. Again, are they how big of a role are they playing?
And they're different ones too, right? There's at least 5 different, many classifications out there, and each one is directed at a different phospholipid. And it's always been a little mysterious to me, but it is definitely, I see it in people with metabolic syndrome. That's when I tend to see it. Some sort of ongoing inflammatory activation. Susan, you wanted me to answer some questions on the restream. Did you have something in mind? No? Because they're not asking questions. They're just making lots of statements on the restream. If you guys have questions, this is the place to ask them for Dr. Yogender. Am I getting it right now?
Right. Thank you, Dr.
Thank you. I don't know why I thought the H was silent, but I did. Let's see if I'm seeing anything here that you guys have interest in, questions about. Have you been looking at the data lately, by the way? The way this surge is going right now?
You mean the spikes that are ongoing?
Yeah.
People are talking. I just want to. I always constantly think about this. Waves. We were talking about this is the third wave, first wave. The United States is a really big country.
Yes, really big.
I advise everyone to. Amtrak does it. I don't work for Amtrak, by the way. It's not a sponsored comment, but Amtrak does a rail pass. You can travel all around the United States for $450. You can spend a whole month there sitting on a train. And I did that a couple of years ago, and I was blown away. Even though I was raised in America, was just how big and how vast the country is, and also culturally,
and how different.
Absolutely.
Yeah, crazy.
And I suspect that when we're talking about the waves, what sort of the Midwest and a lot of the mountain Pacific states are going through, they're going through the first wave right now.
Right. That's my impression too. They've not previously had outbreaks. Now, there's some places that have, and they're getting in trouble again a little bit, but most of what's going on out there are people that never had any really significant cases, and now they're having it. They're having their first wave. And yet what's fascinating to me is we've kind of changed our behavior around hospitalization. Remember early in the outbreak, we were like saying, no, stay home. Only if your O2 level goes down, stay out of the hospital. Now we're like, hey, we got a lot of good treatments. Come on in. We're sort of encouraging people in much, much earlier. And in spite of that, hospitalizations are sort of not that high. Death rate is down, although there was a little spike yesterday. I don't know. I'm sort of, to me, as much as anything, this looks like it's either infecting younger people less at risk, or we're doing a much better job of treating this thing.
I would say it's both, Dr. Drew. I mean, think about it. If you look at it from even an evolutionary perspective, usually any of these viral outbreaks or any infectious outbreaks that come in, it knocks out the weakest link first. And unfortunately, that first wave took out a lot of elderly people. It took out some young people with pre-existing conditions. And sort of, again, talking evolutionary-wise, they're obviously the first ones. Now, the second wave, the ones that they're going to be a much more resilient group, whether immunologically, evolutionary, and then the third wave, fourth wave, so on and so forth. So I'm not surprised from that aspect. There's also some suggestion that the virus is weakened. I don't know how much, I'm going to put into the validity of that, but there could be a possibility of that. And finally, the hospitalization and the management has gotten much better. I think there is the use of ventilators has decreased significantly. I think before it was, you have a patient that is satting, let's say 85, 86, a little respiratory distress.
Yep.
You're getting intubated now. Whereas now I'm seeing that threshold. It's like in the 60s and 70s, where that patient is several days of on BiPAP and CPAP. And you're kind of like, and most of the physicians are like, okay, we don't have a choice here.
Right. Now that just that one thing, that one behavior on our part seems to have made a significant difference in the fatality rate.
I think also the other interesting thing is proning the patients. That has also had
lying prone, anticoagulants of various types. Maybe the dipyridamole will become part of that. Anti-inflammatory steroids making a big difference, being used effectively. Convalescent plasma, I mean, seems like it's doing a little something. The what's the name of the antiviral medication? The remdesivir. The remdesivir. Again, these things have varying sorts of pros and cons, or let's put it this way: advocates and detractors. But it seems to be doing a little something. I personally would love to get my hands more on the Regeneron. That makes perfect sense to me. What do you think? And what else would you like to see in more common practice?
Yeah, I think, again, the important thing, I'll add, Dr. Drew, and I agree 100% with everything you said, is that it's now, I think we know when to give these drugs. I think early on in the pandemic, when we were talking about hydroxychloroquine, we were giving hydroxychloroquine towards the end of like the severe and critical patients.
Right.
Oh, it doesn't work. And across the board, so the first thing they gave, hydroxychloroquine, azithromycin. We were not sure about remdesivir. Some of these other drugs were completely unknown. So I think that's where hydroxychloroquine sort of got a bad rap. Like in any disease, it's important, or pathology, it's important to understand the progression of the disease and the pathology, and so that you can give appropriate pharmacological treatment and therapies. It's like, say, for example, if you have a bacterial infection, I give you Tamiflu, and I say, oh, Tamiflu doesn't work, this is garbage. Well, you're dealing with a bacterial infection.
Right.
So I think, I know some of these other drugs, I can be a little critical, like let's say remdesivir and steroids, but again, it has a role. I don't think it's inappropriate to give it, but drugs like remdesivir and convalescents, you have to get it very early. There's a small, narrow window to give it. And if you give that towards the end, where the immunological phase is really kicked in, of course it's not going to have a major. So I think it's a little better understanding of how the disease, the pathology is, and where to give the appropriate treatment.
Right. And then you and I had a offline conversation about ivermectin. I know that Dr. Zelenko was enthusiastic about it. He was a little unclear when I talked to him about who he chose ivermectin versus who he chose hydroxychloroquine. But it sounds like ivermectin is sort of internationally moving into position as one of the primary antiviral interventions.
Yeah, absolutely. And, and again, I want to say that sometimes we don't agree with each other. Sometimes we take a different approach in medicine. So this is not a question of, is ivermectin better than hydroxychloroquine? I get all these questions all the time. And rank your drugs and stuff like that. But if I were to have active COVID, I think, or like right now, I think I would probably choose ivermectin over hydroxychloroquine. And I have several reasons. One of the main reasons is I think the mechanism of action of how hydroxychloroquine can work, it's a smaller window than with, say, ivermectin. I think even Dr. Zelenko will probably agree that it's more of like an outpatient drug. By the time that patient is in the hospital, hydroxychloroquine and that zinc combination may not necessarily have that much effective. Where when I look at the mechanism of action of ivermectin, if you miss that window period where we could treat someone with hydroxychloroquine, I think ivermectin's window is much more larger. It takes a lot of the pressure away from the clinician. And there's a lot of interesting data. I know I sent you some papers from the Bangladeshi doctors, Broward County, Dr. Ratter, and his team. He's a pulmonologist, critical care doctor. He just published a peer-reviewed journal article on his study on ivermectin, which was interesting because they found that it lowered mortality, but it didn't decrease the ventilator use. But it was a very interesting study. There's a lot of literature coming from Bangladesh right now, and where they're using it on outpatient for the mild to moderate. And there's a doctor, Dr. Mohidin Chowdhury, who's wrote a paper suggesting that ivermectin plus doxycycline is actually a little bit better than hydroxychloroquine and azithromycin. Now, of course, we're going to need more studies and more randomized trials to really make any conclusive statements. But I think it's kind of up there and needs to be discussed a little bit more. It gets a bad rap in the United States because in April, the FDA came out with a sort of an advisory, a warning about the use of ivermectin animal doses in humans. And it was if you look at the advisory, they say do not use animal doses. Well, my first reaction is duh. You don't want large animal doses on humans. It's all about treating appropriately. And I think that's why there's been a sort of a freak out in the U.S. when you say ivermectin. It's a drug that's been around for decades. We use it in Asia and Africa for a lot of these parasitic infections. Right.
I used to use it. I used to work at a county where we saw Ascaris and the Chinese liver fluke and all kinds of stuff all the time. We'd use a lot of it. But we used it with respect. Now this protocol is taking it for 4 or 5 days. That's the Bangladesh protocol, right?
Yeah, the Indian doctors, so there's the white paper, the Indian doctors suggested that it's anywhere from 150 to 200 mics per kilogram for 4 to 5 days. And the reason why they suggested this is the half-life of ivermectin is 18 hours. But the protocol that Dr. Ratter used in Miami, I think some of the Cuban doctors were doing, they're using a once-a-week dose of ivermectin, 200 mics on day 1, 7 days later, a second dose. And they're also adding doxycycline. They add doxycycline for the secondary infections.
Right.
It's interesting how, again, there's no consensus on should you be giving it every single day or should you be taking it once a week. But when you're looking at the safety profile of ivermectin, most of the serious complications are going to be diarrhea, constipation, some GI, nausea. There's some possibility of liver enzyme elevation, but it's such a small. At those doses, it's not really that much of a concern.
So I need some help interpreting some data. I have to comment on a study tonight put out allegedly by the American Academy of Pediatrics, stating that as of October 29th, more than 853,000 children had tested positive for COVID-19. I assume that means worldwide. 200,000 in October alone. 61,000 are the last week of the month. Again, that has to be internationally, correct?
Yes, yeah, absolutely.
Yeah. Okay. And they don't get sick. Why are they even reporting that? What are they talking about? And there was a huge study that came out last week that showed amongst 55,000 children, zero transmission. What am I supposed to do with these numbers?
Well, first of all, I think the kids, the numbers we're seeing in the children are because the schools opened up.
Of course.
Initially, we locked everything down, and it was very hard. And this is why I've not been a big fan of the lockdowns. I don't think it's really done much. I think social distancing, wearing a mask, hand washing, all of that, definitely. But the lockdowns where it's like a pressure cooker. At some point, you're going to have to face the reality. And I think we're sort of, once we open things up, the kids, I'm not surprised now seeing those numbers. But if you look at the kids.
But they don't get sick.
Well, that's because, if you look at the epidemiology, it's, most of the numbers, you're starting to see anyone above 45 is when you actually start to see that increase. And it gets more pronounced after someone's 65 to 70. I think the mortality rate is something like 25% in people that are 80 years old. Because, again, their immunology is not as balanced as it is on a younger patient. Their immune systems are not reacting as well as it was when they were, let's say, 5, 6, or in their younger years. So I'm not surprised. I guess the concern has always been about these children transmitting that infections to someone older. But it seems like from some of the data you're saying, that's not even happening.
Yeah. To me, it's baffling that that somebody made that a headline. I don't get it. I just don't get it. The reality is, and in this one article I'm reading, they've even embedded a little bit of they're hedging their bet. Let me see if I can find this. Oh, even if they don't get sick or show symptoms, children are being affected by other aspects of the pandemic. Yeah, the lockdown. That's the part that's really affecting them, right?
It's you're taking away, kids can't graduate from middle school and elementary school and high school. You're taking away their important formative years, making these bonds and connections. And
absolutely. And God only knows what else cognitively. And the most at-risk kids are the ones getting hurt the most, for sure. Ugh.
And another thing, Dr. Drew, I've sort of thought in my head, like, what would be a best way of approaching this? And I think, I think people with pre-existing conditions, I think elderly people, we should maybe have them working out of homes and away from and more social distancing. And maybe they should sort of, I don't want to use the word lockdown, but maybe they shouldn't be exposed as much as someone that's younger.
Sure. Of course.
That seems to be a much more, I don't know, at least for me, a good compromise where we're not opening everything up, but at the same time, we're not just shutting everything down and people.
No, it is the difference between heedlessness and hysterical, right? We're being hysterical, and then people are pushing back by being heedless. Neither are good. Both are a problem. And we have to, navigate, be reasonable, humbly. But,
And I think, Dr. Drew, the one other thing I would like to add on is I think we also need to be a little bit more kinder to each other.
Mm-hmm.
There's a lot of this mask shaming you hear about. You're walking down the street and someone's got their mask under their nose and someone's yelling at each other. I was at the supermarket a couple of days ago. There was a fight breaking out. And I will say this, there's this narrative about, wearing a mask prevents COVID. No, it's a series of things. Wearing a mask, yes. Social distancing, yes. Washing your hands, yes. It's all of those they all play a major role. So people sometimes get this false impression. How many times have we been at the store and we see someone scratching the mask and then they're touching their eyes? I mean,
of course.
So, and the other thing is, there have been people that have told me, well, I have a medical condition. I have claustrophobic and I get anxiety when something's on my face. And I think it's sometimes easy to say, well, these guys, they're libertarians and they're infringing on their rights.
Right.
I don't want to, but here's I will say this. I empathize with a lot of those patients, a lot of those people that tell me that, because in anesthesia, and I've put to sleep thousands of patients, I can't put the numbers, but I always have these patients at least once or twice a month that when I put my mask on them, they freak out, or they'll tell me in pre-op, like, Dr. Yogendra, like, I do not want that mask.
I know. Listen, it's one of the reasons I didn't become a surgeon. I don't like wearing a mask all day. It drives me crazy. But I'm learning to live with it.
They hate things on their face. Even that operating room, my mask that I put before I put them to sleep,
Yep.
they hate them. What we talk. We have a conversation with them. I said, okay, I put a nasal cannula on there. Sometimes I'll have them hold the mask. And I think we need to be much more kinder as a society. And even as physicians, sometimes things get so politicized.
I know. Well, we'll see. Hopefully this election will solve something. I don't know what, but get us through something. Get us on the other side. Maybe. Are we there yet? I'm not watching the news at all. Are we getting closer?
Well,
here we go.
It's close, so close. But I'm adding this up right now. Somebody said before the stream, the boys were watching the news and it looked like Joe Biden was going to win. But Joe Biden was saying that. And then Joe
Biden will win.
If he gets Nevada, he'll have 6 more votes. He'll be at 270.
Okay.
What do they need?
270.
Okay, but is that right? 6 and 4, yeah, 270. But if Donald Trump wins Pennsylvania, North Carolina, and Georgia, he'll have 283.
I don't want to.
So what does that mean?
It means stop watching TV.
Well, I'm looking.
Tell me when it's over.
I'm looking at the numbers, but is it whoever gets there first, or is it?
No, it's whoever lands. Once you get there, you're there. If you get over 270.
Yeah, but
so I really
because I'm apolitical. Explain this to me. So if one gets 283 and one gets 270, who wins?
That's more than there are.
Wait, then how come 214? All right, never mind. I give up.
Is it the first 270? Am I getting that wrong? Somebody's got to help me. It doesn't make sense that it would be the first to 270 because the total number is what counts. So
yeah, it's weird because if you add up Pennsylvania 20 and you add up 50,
the bottom line
45,
is
51.
I don't want to know anything until 14. It's over.
Oh, you know what? I added up that wrong.
Thank you very much.
It looks like Biden.
I would like to see the results when there are results and everyone agrees those are the results, and that'll be 51. That. Then
oh, you're right. Okay, so Joe Biden, it looks like he's got it in the bag if he gets Nevada.
Okay, the if.
I mean, it's 588,000 to 580,000. That's
so crazy how close this is.
I know. So it's 8,000 people are going to.
Somebody's going to be unhappy.
But it wouldn't even matter because even if Trump got Pennsylvania, North Carolina,
also,
Georgia, it wouldn't
Andrew
matter.
Ashkazvili is reminding us that Arizona is not done. Arizona is in play still.
Arizona is?
Yep, it still is. And Pennsylvania, Georgia also. So anyway, whatever.
Oh, I see. Maybe there's more. But the way that the Associated Press
the panic porn
shows it.
Still.
No, I mean, I think it's going to be Biden. But listen, tomorrow that could change. Who knows?
Kelly Gallagher she was shocked that Oregon has legalized cocaine and heroin. They're just following what we're doing here in California. I told you.
Really?
I told you the same thing here in California.
We can have cocaine and heroin here?
You can. Well, you might get a ticket, but the cops won't bother you.
It's a misdemeanor.
Yeah, it's not even. The cops won't bother you. They don't. It's not even worth it to them to write the.
How about
the
New York?
No, New York, you go to jail. But here, not only Kelly Gallagher can you use it, you can steal and traffic in drugs. So we've taken it all the way. We're all the way in California. And I'll just refer you to our streets to see the consequences. People are dying at the rate of 4 a day in LA County alone. So there you go. Okay. So, well, you've got a lot coming up, my friend, with this new project. I'm really anxious to see what you guys do and what I can do to support it. It's pretty exciting with the Long Hauler project.
Yeah, we are beyond excited. I think again, it's taking the science and really bringing it to really making an impact on people's lives. I'm thinking I change my prescribing practices even like this week. I think Persantine is now in the mix for me. I think Ivermectin is up front. I think quercetin and zinc seems a little more solid to me as at least something to take on an ongoing basis. Steroids. Any thoughts on when to use the steroids? I'm still in that school of thought, but sort of towards that critical end. And maybe my thinking has been influenced by that study in England. But I got friends of mine that are taking steroids in the early part of the infection, and they're doing well. So,
yeah, I think I would take it in medium course, right? Right. When I had H1N1, as I look back on that, I feel like, God, if they'd given me a little some steroid, it might have really helped me, because I had 2 weeks of hell with that thing. Really bad.
What's interesting is we're seeing elevated cytokines even in the mild COVID patients, and this is also seeing with the long haulers where people they're in the most of them. I got to crank out the data, but I would say like 90+% of the people that we're testing are mild to moderates. So Dr. Patterson's already tested these the active COVID mild to moderates, seeing elevated cytokines there. So it's not in this. There's this. Day 5, the virus is gone, and then the cytokines come in. There's a lot of overlap that's taking place here.
Yeah.
And, so I think it makes sense when you're looking at the mechanism of action, the immunology, to consider giving steroids very early in the disease. But I think there's also a certain point where and maybe it might be in the middle part as the patient is trending to that severe COVID, where giving the steroids can be more harmful.
And people want an update on leronlimab.
I have no updates. I don't work for Cytidine, by the way. I think people think I all this information. No idea. I know they did their interim analysis, the DSMB, which is the board that reviews the studies at the halfway point. They asked them to continue it, and they were told to come back at 75% when they have enroll 75% of the patients. So I have no idea.
We don't know where they are. Any thoughts on budesonide as a treatment, this inhaled corticosteroid?
Again, it's Dr. Richard Bartlett out in Texas. He started using that. I believe he's either emergency room or family practice doctor. Again, it goes to what we were talking about, Dr. Drew. I think it's one medication. Very early COVID, I don't see any harm in that.
Right.
In fact, it's not a systemic steroid. You're delivering that steroid right into the respiratory tract. And,
yep.
Potentially helping with the inflammation there. Again, Dr. Bartlett is claiming, and he hasn't put out any studies yet, but he said he's treated a lot of patients, and they've responded really well to budesonide.
And then finally, any thoughts on vaccine therapies from your perspective?
I'm still cautiously optimistic. We will have a vaccine. One of the things, again, I think this goes back to the whole lockdown discussion. I think there was this initially that we'll lock everything down for a couple of weeks because this vaccine is going to come out in 3 months.
Right.
That was just unrealistic. You're talking about the platforms we're talking about, the mRNA, and the DNA, and the adenovirus that Medical Oxford are doing. They've never been used successfully. They've never been used in humans, let alone successfully. So you're using a new method of delivering a vaccine, and you're thinking you can get it out in a couple of months.
I'm not sure that's right. I think that the RNA vaccines have been used for Ebola, and there was something about the way they're developed. They're much quicker to develop than some of the other vaccines.
Yeah, you're right. But I guess I was saying in terms of a successful vaccine.
Not in the U.S. Never in the U.S. That's for sure.
It's been experimented.
Yeah.
Never in the U.S. Right. And there's not been any success. I don't mean to say like this is the first time they're doing it. They were obviously doing experiments on it. It's just we don't have a successful vaccine that's been used using these platforms. And you're right about the scalability. And I think that's where the appeal comes is these can be quickly scaled. Whereas if you're talking about the live attenuated vaccines, they take several months and years. It can take, I think, up to like 18 months to get those vaccines.
Right.
But what's interesting is there are some of these other drugs. I just interviewed the CEO, a doctor with Tonix Pharmaceuticals a couple of days ago. So they are developing a live vaccine. And if you're looking at the sort of the timeline to it, it might end up where all of these medications all these vaccines come out at the same time, even though we were trying to think of these experimental or these mRNA, DNA maybe a little bit faster. I think we might be looking at springtime. Live attenuated guys are going to be right there. We were talking about the hair analogy that all right, these guys had a head start, but maybe at the end they're kind of all at the finish line together.
And again, the live attenuated is old-fashioned vaccine therapy, and Dr. Offit, I think, was the one that said that's the one he'd go for.
and to be honest with you, I think that's the one I would probably feel the most comfortable with, just because again, it's tried, it's tested, it's.
I would feel the most comfortable with that, but I think I would take one of the other ones if they came earlier.
Yeah, for me, it depends on the efficacy and the data. If we have the data and we have the efficacy, then I don't see a problem. But
right,
it has to be very concrete and not iffy like remdesivir, which was pushed through and which is a big puzzle why they got full approval.
Hey Susan, what did GSR, you and your psychics?
He said, oh, the psychics called it, and I said, yep. I was just gonna give him some creds.
Anarchy is saying, who cares if there's a vaccine if no one dies from the disease? Yes, I understand. I understand if you are young and you don't feel you are at significant risk, that getting the disease is less dangerous than an untested vaccine. I understand that, and so you might want to wait. Andrew's asking us, his 1-year-old got a flu shot today, and the pediatrician said, come back in 30 days for a booster. I'm not a pediatrician, so I didn't realize. Do they boost the flu shots? I'm not aware of that.
That's the first time I actually just got I just got a flu, the inhaled version. I hate needles. I know. I'm a little baby about
You're an anesthesiologist. You're sticking needles in people all day long.
I cringe, and but so they actually had the flu mist, the flu vent.
Yeah.
Awesome.
Yeah, I took the shot. It was fine. No big deal. All right, my friend. Well, good to talk to you. I'm going to let you go. We will. Where do you want people to keep track of things so they can, see the landing page when it goes live?
Yeah, it's so I'll post everything on Yo, Dr. Yo. Dr. Patterson is Bruce P13. So both of us are posting a lot of the research, and like I said, we're testing the chronic COVID patients. I've had my email there, my contact info. Probably getting about 50 to 75 requests even without a web page now. So it's been a lot of work, but we're taking all the requests, and they can reach out, and we'll get them onboarded and tested.
I think it's great what you're doing. Anything else besides that project occupying you?
Well, there's, and we can talk about this in a couple of weeks, Dr. Drew, but there's some very interesting galectin research that's coming from India that I've been sort of involved with. There is a researcher named Dr. David Platt. I'll post his, I think he's going to release this study in about 2 weeks. I'll sort of give you a little hint about what things, they looked at galectin inhibitor. He's a CEO of a company called Bioxytran. And they looked at a drug that's a galectin. We talked a little bit about galectins, with these carbohydrate proteins in the body. And there was research that suggested the spike proteins on COVID-19, those are the spikes that stick out of it, they're covered by a sugar. And the theory has been that could the galectins that are found normally in humans, they mapped it out, and they said it looks exactly like identical to the COVID-19 spike, the covering, the sugar covering. So the theory has been, if you use a galectin inhibitor, would it also work to block or sort of coat that the spike protein of COVID? It's almost like how Regeneron's monoclonal antibodies are, where you're using monoclonal antibodies to neutralize the virus.
Yeah.
The galectin inhibitors work almost the same way, except you're not using an antibody. You're basically using a sugar molecule. You put a sugar that it's attracted to the sugar covering of the spike protein. Well, they did a small clinical trial in India, just on 10 patients, a proof of concept. And all 5 patients that had the galectin inhibitor all had a 0 COVID-19 viral load after 3 days.
That's pretty amazing.
Compared to controls, and they had IgG levels, their immune response shot off the roof compared to the controls. So this study is coming out in a couple of weeks, probably in about 2 weeks. They have just got approved for a 400-patient trial in India. It's a 200 with the galectin inhibitor, 200 on a control arm, and it's going to be pretty exciting. So I'll have some information for you on that in the next couple.
When is that likely to be done? Any idea?
Well, they just finished a 10-patient one. They just got approval from the hospital IRB in India. This is a US-based company that are doing the trials out there. I know they are talking to the FDA and the NIH right now for getting grants and funding to do that 400-patient trial.
It's fantastic. All right, my friend. Well, we'll talk about that and other things, no doubt, in the very near future. So thank you for spending a little time with us.
Sounds good. Thanks, Dr. Drew. And
All
thanks,
right.
Susan, for having me on. Thank you.
Look at Yo
Thank you.
Doctor, the words of Doctor spell out, Yo at Yo Doctor Yo, Dr. Ram Yogendra. Thank you so much for joining me. Let me review some of your questions here on the restream. Susan, anything you want to hit before we kind of wrap
I'm
things
trying
up?
to find my show where we had those predictions.
Oh.
I can't find it. For
Hey,
some reason.
until this thing is codified, don't make any fast moves. Just
I can't change what the psychic said.
Stay away from the TV. Stay away from the TV until this thing is settled.
Hee hee.
I have a feeling we're going to see courts
Well, I know
and
it's
all
going to
kinds
be.
of stuff
Yeah,
yet.
I mean, come on.
It just seems to me it's going to happen, and I don't want to hear any of it. I don't want any part of it. Okay. So in the restream, any questions before I wrap things up? Again, we are in a bit of a surge here, but the surge is not affecting the death rate. However, yesterday there was a significant little spike. I don't know if that's real or not. We'll have to see in the next couple of days. California is doing crazy well. Hospitalization's been flat for a month and a half. Death rate just continues to drop down. Death rate overall in the country is kind of all over the place. And when you look at most of the states where there had never been a surge before, who are finally getting their first outbreak, you're not seeing a significant uptick in most of those states in the death rate. What is interesting to me, though, I was looking around Wisconsin and Minnesota and all those states, and you know how they say the hospitalization rate is a lagging indicator? Not anymore. It does not appear to be in those states that are getting their first surge. The hospitalization rate started going up right at the same time as the case rate, which is, again, more evidence of what I think I'm seeing, which is that me and my peers are encouraging people into the hospital earlier for some of these fancier treatments we can give people. So that's interesting. And then the death rate is either flat or down. Some states it went up, but most of the states in which it went up were states that really didn't have much going on to begin with in terms of fatality rates. So it went from like 3 to 12, something like that. So it looks like a significant uptick. But overall, the country is in an uptick of hospitalization cases and maybe in the death rate. I mean, it was sort of percolating around 900, maybe 1,000. And then yesterday, suddenly it's 1,500. Now, again, sometimes that's a backlog, sometimes that's a fluke, but we'll have to see if that's a real number or not. That's still nowhere near the where were we in May? 2,750 we were at in May. When we were at a much lower number of cases. Again, the cases were 27,000 and the hospitalization rate was 60,000. Now it is nearly 100,000 with a hospitalization rate of 50,000. And again, when there was 30,000, the death rate was 2,700. And now when there's nearly 100,000, the death rate is about 900. So we're generally doing a lot better. Still a lot of people entangled in this thing. But again, it's mostly at risk. On Fox 11 tonight, Susan, they want me to talk about a study. This is what I brought up with Yohendra. Some more panic porn. New York Daily News.
That's going to slow down if Biden's in office. Nobody
The
will have
panic
anything
porn?
to talk about.
We'll see. And maybe they'll just continue it.
Nah. Because it won't be Trump's fault anymore.
And I looked I looked up the response I found, and this is a largest peer-reviewed study. 57,000 child care centers. No evidence of child care being a contributor to COVID-19 transmission to adults. Finding consistent with previous studies showing lack of association between school closure and transmission rates. So, I mean, what are you going to do? Which is it? Is it oh my God, 600,000 kids have had it? No, they've not even had it. They've been infected with it. You can't even call them COVID-19 cases. Let's see. That's in pediatrics. And that was in pediatrics, one of the premier journals. And when was that? Let me see. Trying to see when that was. Hopefully it was relatively recently. Hard to see. It's definitely in 2020. I'm sorry. I can't. That's weird. Yeah, I'm really anxious to see when that was. Oh well. Okay. Can't quite see it.
I can't find this video.
What video is that?
My psychic prediction show. I don't think I put it on Dr. Drew's platform. I think it was before we started pissing off people on your platform.
Okay, well, good.
When I finally just said, "Oh, forget it. We're going to do it."
Let's see. Everywhere on the news, they're saying pregnant women who have symptoms are more likely to die. Is that true?
No.
Pregnant women don't die of COVID. It's very unusual.
Because of the progesterone levels.
Very unusual. The children tend to not get it, though they can, and they can affect term of birth, that kind of thing, but generally it doesn't. Let's see. Yes, the media is not interested in logic or facts, just fear. Why are you guys writing Steven Crowder's name down over and over?
Who is that?
He's got a Louder with Crowder podcast, I think. Minks in, here's panic porn. Minks in Denmark mutating COVID and spreading it. Yeah, no animal spread that I'm aware of. Doesn't mean it couldn't happen, but not that I'm aware of. All right, let's wrap things up here.
I got it. I can't find it.
Yes, I saw the minks in Denmark. In fact, give me a link to that if you guys have that report. We can push out some real panic porn here. Why not? Tomorrow, Susan, or
I don't know. I just got a call from Daphne.
Oh yeah, good.
She went. What's going on with
Daphne is the filmmaker of the Amy Winehouse documentary. And then she has some documentary she wants to tell us about.
About Beos.
About who?
Beos? I don't know.
No, I think it's a group of African American musicians that are supporting President Trump or something. Or So
no, I did this crazy prediction show. I can't find it.
Okay.
It's driving me crazy. It's high.
A rapid COVID-19 test accurate? The rapid antigen test is pretty accurate. The gold standard is still the PCR, though.
This has been a long time ago. Was it the end of the year?
All right.
I think it was at the end of the year, maybe.
Yeah, you're asking about the peptide-based vaccine. No, they're all equally safe based on the data we have. However, the attenuated proteins, attenuated viruses, peptides, those sort of things are time-honored, and so we have more experience with those things, which makes us feel more comfortable with them. That's that. Sebastian, you're from Denmark. What's going on with the minks there? Tell me about that. Okay. All right, so let's wrap this thing up. Halloween party, Kelly Gallagher, was a lot of fun. You saw how I was dressed. It was very embarrassing.
It was fun. Everybody said you looked great.
It was a great
Everybody
costume.
wanted a picture.
Yep. How long is a person with COVID contagious?
There was another set of...
generally 2 weeks, right?
And
quarantine for 2 weeks, and then they're fine. I actually think it's 7 days after symptoms subside. You're really in good shape if you want. Thank you, GSR. They want Paulina back on the show. So
I know. You guys will be getting some Paulina next year.
Yes,
we have a new book.
We have a book coming out, and so we'll come out with that. Anything else, Susan?
No. I don't know. We could probably...
Oh, Bentley, Kelly Gallagher, Bentley, Macy's son dressed like me for Halloween. That is too funny. I didn't know about that. Or did he dress like me as me or me as Joe Exotic? So, Joe Exotic. He was Joe Exotic.
Yeah, it was a great costume. Yeah. I got it on Amazon in like 5 minutes.
Apparently, it was the most common costume of the
easy
Halloween.
If you're a white guy.
Right, exactly. Since we're discussing someone who's infected with COVID-19, antibodies offer... Okay, I meant to bring with Yo, so I'm glad you brought this up. Okay, the question is, COVID-19 antibodies only offer protection for a limited amount of time, then it seems logical that the herd immunity will never be achieved. Okay, wrong. There's a big article that just came out today that showed that antibodies normally decline within 6 months, and that does not imply that you are not immune. You still have memory B cells and cellular immunity that remains behind, ready to activate in response to the presence of the virus should it be a re-exposure. So, like I said, with additics, we're going to have a specific way of measuring that. But the fact is that some large articles, consensus articles, came out today saying the decay of the antibody is normal and it does not imply a lack of immunity. So even though antibodies decay, you are probably still immune because of the memory B cells ready to release more antibody and the helper T cells that recognize the virus when it shows up. So that's not something we need to worry about, the decay of the antibodies. That is not going to be an issue in the vaccine, and it does not seem to be a significant issue in COVID. Now, people seem to be, the potential for reinfection seems to exist. There have been a half a dozen cases or so where that has been documented. Now, is that a different virus, a mutation, something about that person's immune system? We'll study it. It's rare. So it's not something we should be really thinking that much about. Obviously, if you want to protect yourself, wear a mask, do all that good stuff that people are doing, fine. But the science does not bear up that a drop in antibody doesn't necessarily implies that the immunity is dropping off. But more to be revealed like that as we go along. Yeah, Toby, calm down, people. That's what he says. I agree with that.
It's going to be calm now.
Well, we'll see. Let's get through this. We're not through this election
Bye-bye,
yet.
Trump.
Yeah, you think we're through it. I'm not sure we're through it yet, so we'll see. All right, we'll see you guys.
I know you're a pessimist, but it looks like he's gonna. Even if Trump got everything, he wouldn't have enough. I mean, unless there's some data that says somebody cheated or whatever.
Right. So I see loss. I see courtrooms ahead. So 2:30 tomorrow. Is that correct, Susan? Or 3?
I don't know, 3:00-ish.
3.
I don't know. We have to
yes,
set
3
something
o'clock
up.
tomorrow. 3 o'clock. Right. 3 o'clock tomorrow. We will see you then.
Real talk.
Headlines have become sickening. They become poisonous.
Dissecting headlines.
Defying state orders. Sheriff Bianco not enforcing what the governor is saying.
Dialed in with decision makers.
Clarify what you actually meant.
Get the answers you need.
Beginning of this, we were told don't wear a mask. Is this really helping?
Expect a different kind of newscast. Fox 11 News Special Report. Weeknights at 7.